He's the director of statewide stewardship program and co-chair of the Infection Clinical Network. So to start.
Thanks very much, Teresa. I'll just, oh, hang on. Yep.
So Northern Australia is, when we refer to Northern Australia, this is the large geographical region that you can see there. It covers three main jurisdictions, which are Western Australia, Northern Territory and Queensland. It is an absolutely amazing and beautiful region, and I was quite privileged to have been able to work there. In terms of the population, approximately a quarter of the population are Aboriginal and Torres Strait Islander. As much as 49% live in what is considered remote setting. The remote clinics are very small there and experience very high staff turnover and make considerable use of agency nurses. A couple of studies have shown that the stability rates are as low as only 20% of nurses and Aboriginal healthcare practitioners working, continuing to work at specific remote clinics at the end of 12 months, and as much as 50% of them leaving within the first 4 months. So these are quite alarming staffing patterns, and as you can appreciate, would incur significant cost on the service provision, but certainly long-term sustainability and suboptimal continuity of care. Additionally, a lot of the healthcare workers in this region are actually fly in, fly out, and they come from all across the country and often for short periods of time. So education about local antibiotic resistance and the use of local treatment guidelines is really key. There's also limited capacity to diagnose, which includes both technical expertise and equipment-wise. And like I said, it is a very geographically isolated area, and actually the main form of transport for patients is aeromedical evacuations. So if we take a snapshot at any one time, skin infections are the predominant cause of the burden, as much as in remote communities, as much as 75% of community members present to the clinic with a skin soft tissue infection. And it is also the most common indication for antimicrobial treatment. Both nurses and doctors prescribe in clinics, and surprisingly, Will Cunningham study found that Aboriginal health workers who are actually trained and encouraged to prescribe are not necessarily prescribing. In terms of doctors, it's mostly doctors prescribing in Queensland and Western Australia, and predominantly nurses, and as much as 72% in the Northern Territory nurses are actually prescribing in the Northern Territory. There's a high burden of impetigo, as much as 45% of children have this infection, which is a study done by Asha Bowen, who will be presenting later. 95% of children have at least one antibiotic, and 47% receive 6 antibiotic scripts before their first birthday. So clearly a very high antimicrobial usage in this region. If we take Steph aureus as an example of the situation of AMR in Northern Australia, we can see that the rates of MRSA are quite significant. This is shown in this graph, it's showing the green line. This also varies quite a lot between the three jurisdictions of the western parts, showing as much as 46% MRSA. Northern Territory, approximately an average over the years that we had data for, 35%, and 26% in far north Queensland region. So the prevalence of MRSA in this region means that people can no longer rely on simple first-line antibiotics for treatment. And as you can appreciate, treatment failures because of resistance means that these infections can no longer get better and are more likely to spread to other people, are more likely to then proceed to become a more severe invasive infection such as a blood or a lung infection. And then this obviously then has significant consequences. Patients are likely to then have to be flown to a hospital thousands of kilometres away from community and their support networks. The other thing I wanted to show you with this graph was the blue line, and it shows resistance of Staph aureus to clindamycin. And it's sitting at approximately 20% for Western Australia and Northern Territory, and about half of that in Queensland. However, if we look at MRSA co-resistant to clindamycin, it's quite a worry. We can see here MRSA and clindamycin in this 3 graphs here in Western Australia, Northern Territory and Queensland. As much as a quarter of MRSA blood isolates in this part of Northern Australia are resistant to inducible clindamycin. And these rates in MRSA are worryingly high and are a local impediment, an impediment to empiric use of agents to treat community MRSA. So it's a complex region, but not only for the type of infections that we see, but also for the underlying comorbidities and other conditions. So this is a couple of pictures that Professor Bart Curry shared with me, and it shows patients here who is a 16-year-old boy, came into hospital with quite obvious scabies scars and active infection. But was not even on the radar and was actually considered to be a healthy male. So it is alarming that patients such as this boy are considered healthy and that diseases are normalized. And that's it from me. Trent?
Thanks very much, Teresa. Let me just share my presentation. There we go. So thank you very much to the NCAS team for asking me to be part of the webinar today. And I'd also just like to acknowledge the traditional owners of the land on which we're all meeting, which in my case at the moment is the Jabbergai people of the northern beaches of Cairns. So I'm just going to provide a little bit of extra background about what's happening in far north Queensland, looking at some work that I've done over the last number of years. So I guess it's just to highlight that as Teresa said, there's a very significant burden of infection in people who live in remote areas. And so these graphs are old data now, but some work that was done by the Queensland Health Statistical Services branch. And this was your likelihood of being admitted, so the age standardised rate of hospital admission with an infection. And it stratified people in the graph on the left by their degree of rurality. And you can see that the two green bars are the 2 green lines, sorry, are people who lived in remote or very remote classification according to the ASGS, and that the orange bars were people who lived in inner regional, outer regional or metro areas. So there's a very, very significant risk of being hospitalised with an infection if you live in a remote area or a rural area. And the graph on the right looks at the same marker, but stratified according to socioeconomic status. And so you can see that the more disadvantaged you are, the more likely you are also to be admitted to hospital with an infection. And the double whammy for people who live in regional Australia is that not only are you living remotely, but also you're significantly more likely to be disadvantaged. And this was from the Health of Queensland's report a few years ago, and you can see that the difference between the blue bars and the green bars is the overrepresentation or underrepresentation of that socioeconomic stratum in Cairns and Hinterland and Torres and Cape Hospital and Health Services, which are the 2 health services that make up the bulk of the pointy bit of North Queensland. And you can see that in Cairns, we had a 12% overrepresentation of people in the most disadvantaged quintile, and that in Torres and Cape, the vast majority, almost 3/4 of people were in that most disadvantaged strata. And as Teresa said, we also have high rates of infection. We have also very high rates of MRSA. An audit that a medical student at KAMS Hospital did with one of our outreach physicians a few years ago found that almost 3/4 of the staff isolates that came through Cooktown were MRSA, and that the vast majority of those were actually from Hopevale, which is an Indigenous community not too far outside of Cooktown. As has already been said, there's often very limited access to primary care, lots of fly-in, fly-out staff, and very few specialist infection staff. Obviously there's none outside of Cairns in this northern part of Queensland. Following up on the skin disease thread, this is some work that I did when I worked at the public health unit in Cairns a few years ago. And this is just looking at rates of invasive group A streptococcal disease. So not simple cellulitis. This is people who had bacteremia or who had necrotizing fasciitis or who had other invasive infections associated with group A strep. And the vast majority of these come about from skin and soft tissue infections, which then progress. You can see that there's an enormous disparity in the rates between Indigenous and non-Indigenous Australians, but that even this rate of 29 per 100,000 person years in non-Indigenous people is quite significantly higher than has been reported in a number of other series. And so, it's something that we very frequently hear from the surgical trainees who come to Cairns Hospital. They say, oh my goodness, I just can't believe how much terrible cellulitis and necrotizing fasciitis we see in the north of Australia. And obviously, if you're an Aboriginal or Torres Strait Islander Australian, that this rate increases enormously. We also looked at, I guess thinking down the pipeline a little bit. There's obviously been some work over a good number of years now looking at a vaccine against group A strep, but there's many different strains of group A strep, and that only around a third of the ones that we found in this audit were in fact strains that would be covered by the candidate vaccine. And just another area of I guess, remote disadvantage, or as you can see, the graph on the left is the rates of chlamydia in Aboriginal and Torres Strait Islander Australians in the blue versus non-Indigenous Australians in green. That it's of the order of 500 times more likely that you'll have a chlamydia diagnosis if you're an Indigenous Australian. And the graph on the right is looking at notifications of infectious syphilis by regional status, and you can see that all across the north of Australia, including the Northern Territory and Western Australia, we're seeing a very significant increase in rates of infectious syphilis over the last few years. And looking at, I guess, disease notifications more generally, I won't go into all the figures in this table, but you can see, I guess, the difference between the last and the second last columns are important. The final column is the notification rate per 100,000 population year per year for all of Queensland, and the second last column were the notifications in Far North Queensland in 2014. So, vastly higher rates of sexually transmitted disease, moderately higher rates of gastrointestinal disease, vector-borne is, I guess, understandable, double the rates of other diseases, 50% increased rates of notification of mycobacterial disease, and that overall, much higher burden even of just disease notifications in the north of Queensland compared to the rest of the state. And finally, just in terms of economic impact of these infections, obviously Cairns is certainly not rural by any stretch of the imagination, but we're obviously the feeder hospital for large parts of the hinterland and Cape York, and that an infectious diagnosis accounts overall for about 1 in 7 separations through the hospital, and about 1 in 6 costs, a sixth of the total health service cost over the 5 years to 2015, with a yearly cost to our health service of in excess of $48 million. And that if you just look at the 5 most frequent infections, the top 5 that I've listed there, so pneumonia, skin soft tissue infection, gastrointestinal infection, bloodstream infections, and surgical site infections, together those 5 infections account for more than 10% of our health services expenditure each year. So that was I guess the Queensland specific data that I had to speak about. So I will stop sharing my screen, and I will hand back to Teresa, who I think is going to pass on to Asha Bowen.
Yeah, thanks so much, Trent. So the next presenters are Associate Professor Asha Bowen, who is a clinician scientist. She works both as a pediatric infectious disease specialist at the Perth Children's Hospital, where one of her activities includes antimicrobial stewardship rounds, and leads the Healthy Skin team at Telethon Kids Institute. She works closely in partnership with communities in the Kimberley to reduce the burden of skin infections for remote Aboriginal children. The other speaker is Trent, I believe, as well, who we've already introduced, and as well as Dr. Caitlyn White. Caitlyn is a GP currently training in public health medicine at Kimberley Aboriginal Medical Service in Broome. She regularly provides primary health care in remote Aboriginal communities while also working on public health projects and policy. Over to you.
Hi everyone. I am just trying to share my screen, and Trent, I'm going to shout it out. I think you're still sharing.
Oh,
I'm wondering whether you can change that. Sorry, Trent. Here we go. Should be good now. So my name is Asha Bowen, and I've been introduced already. And I guess thanks so much to Trent and to Teresa for setting the scene for the burden of this problem. And my slide did say introducing the Antimicrobial Academy, but that bit has fallen off. So I will also bring my acknowledgement to country and recognise that where I sit today in Perth, have the beautiful privilege of, I guess, living, working and walking on Wajak Budja, the land of the Noongar people, and pay respects to elders past, present and emergent. And in a national, I guess, meeting, really draw our attention to how advocating around something like antimicrobial stewardship and antimicrobial resistance can also bring us to advocate for better health outcomes for First Nations people in our country, and continuously draw our attention back to the Uluru Statement from the Heart. So another thing that I have learnt over the years is that the real importance of positioning and placing, and I do have the privilege of working at Perth Children's Hospital and also on the beautiful country up in the Kimberley region, and you can see our four-wheel drive is bogged. You can see our team celebrating after birthday on Cable Beach, and also I guess the opportunity to work in some amazing country is only possible for each and every one of us through the support of those who've gone before us, our parents, our grandparents, our mentors, as well as those who we hold close and stay with us, so our children and our partners and a broader family. So acknowledge the importance that they bring to the work we do. And then also, I guess, position the story. And so I grew up in Sydney, in, I guess, beautiful country there, had some time in Tasmania, moved up to Darwin and worked up there doing my PhD for about 5 years with some time in Alice Springs, and now live in Perth, but travel regularly up to the shaded white zone at the top of Western Australia, which is the Kimberley region. Some highlights of my career, I think when I was in Central Australia, and this is at a clinic in Docker River, a camel came to visit. Working with children across the Western Australian region to produce hip hop videos, and there's some boys down the bottom who were in one of those videos for health promotion purposes, and also I guess recognising the privilege of flying over country and into country to provide both healthcare and continuously do research. So the reason for a Hot North Antimicrobial Academy, I think that Teresa and Trent have really positioned the heavy infectious diseases burden and the high antimicrobial use, which we would assume accompanies that. And so the assumption was there, and it was well recognised and discussed that antimicrobial use was high, but due to a variety of reasons, it was poorly documented. And so that spreads from both the issue where skin infections are, where infections are somewhat cheaper antibiotics to use, and so there wasn't a lot of regulation around that, and also I guess the need for better stewardship and audit processes to develop, which we'll talk through. So some of the slides that Teresa showed earlier were around MRSA. And so as part of my PhD, I led the skin sore trial. And in that trial, we demonstrated that oral cotrimoxazole worked just as well for treatment of skin sores as benzathine penicillin G. So whilst it's a broader spectrum antibiotic, it was great news for kids because it got rid of the pain of the injection that is associated with LA bacillin and a very short course duration of treatment. And so it also had, I guess, that added benefit of being able to treat MRSA infected skin sores, which BPG was less able to do or unable to do. So these findings were incorporated very rapidly into the appropriate guidelines for the region, Takapa therapeutic guidelines and the Kimberley guidelines, to monitor and ask questions about were clinicians actually changing practice based on what was being incorporated into the guidelines, and if that was so, was there resistance emerging? And so critical questions that we must always pay attention to when we alter guidelines and when we change guidelines. And so research that then followed from this was the Hot North Antimicrobial Stewardship pilot. And so this study was done really 2017, 2018, led by Jodie McVernon from Doherty Institute, and with I guess clinician scientists and pharmacists partnering from tertiary hospitals as well as from regional hospitals in the Kimberley, Northern Territory and far north Queensland. And so it was a real partnership, I guess, between NCAS, between people who are involved in antimicrobial stewardship at some of the tertiary hospitals in the southern parts of our country, and working together with those who are in the northern parts of our country to better understand whether an audit tool was appropriate, could it be used, and what could we learn about it. And so I think Will probably present some of these data a little bit later. Two of the findings that we were able to identify through that was that audit tools work just as well in the remote sector as they do in other parts of Australia, which is great news. But we also identified when we were looking to advocate to speak together about this important gap in the National AMR strategy, for example, there were very few Aboriginal and Torres Strait Islander health workers, clinicians, nurses working in remote sectors who were, I guess, working in antimicrobial stewardship, who were upskilled in audit, and who were, I guess, wanting to champion that cause. And so we really felt there was a gap in that translation aspect where capacity building was required to, I guess, share the knowledge and share the space. And even in the sort of on pause due to COVID, when we developed and got the funding for an antimicrobial academy, there's been some really great progress happening already. So imagining it, building it, and sharing it is, I guess, all part of the as well as the gap that is identified for more training required. So this is, I guess, a quick snapshot, and we'll get more into it later. But from this group, which was multidisciplinary across the north, partnering with the south, NCAS involved in it, really demonstrated that skin and soft tissue infections in orange and yellow were one of the dominant reasons for antibiotic prescriptions, which I guess, being a passionate skin infection researcher, did not surprise me, but it's always useful to have some data like this to be able to compare and contrast. And there are, I guess, lots more interesting similarities as well as differences between, say, doctors and nurses prescribing, as well as, I guess, the differences in the burden of these diseases when we go and look at the 3 different jurisdictions in the north of Australia. From this data, we also felt a real commitment to advocacy at a national level about this urgent need for antimicrobial stewardship in the rural and remote areas of the northern parts of Australia, particularly because the burden affects our First Nations people so dramatically. And I guess the conversation when you're thinking about MRSA is running out of effective antibiotics, or being able to treat the person in front of you appropriately with an antibiotic that you know will be effective because of resistance. And so in doing, I guess, these advocacy pieces identified a champion, Lorraine Anderson from the Kimberley Aboriginal Medical Service, who is a proud Palawa woman from Tasmania, and the Director of Medical Services at at KAMS. Shout out to you, Lorraine. I hope you're listening. And I've really been able to partner with and build the academy together, as well as continue to, I guess, put pieces into the MJA, the conversation to I guess, identify a national conversation that was required. So I'm going to pause here and introduce Caitlyn, and Caitlyn's actually going to introduce herself with these beautiful slides, but allow her to, I guess, tell a story about doing an audit in a remote clinic.
Hi everybody, thanks Asha. Thanks for having me today. As Asha said, I'm Caitlyn. I'm a GP and now training in public health medicine at Kimberley Aboriginal Medical Services in Broome. So today I'm here in Broome on Yarwood country, and I'd like to also pay my respects to elders past and present. I have the privilege of working across lots of different communities in the Kimberley, across lots of different lands. You can see my family there. Recently I received my fellowship in general practice, so that's us together there. And you can see a photo there, that's actually me driving the ambulance, taking a patient to the RFDS plane in one of our remote communities during an evacuation. And that again is me on the road between Derby and Broome. I moved to the Kimberley in 2011 as a medical student, and I did a year of med school in Derby, and since then went back to Perth and then came back up to Derby a couple of times to work, finishing my GP training there at the Aboriginal Health Service last year. And now I've moved down to Broome to train in public health medicine, and am fortunate to continue to provide primary health care to remote communities through my work at KAMS. So Asha, I think I can go to the next slide. That's all about me.
There we go.
Thank you. So as Asha said, Lorraine is the medical director here at KAMS, and with her I worked on an Aboriginal, an antimicrobial stewardship audit, particularly for KAMS, who was involved in the work that Asha did before. But last year we sort of piloted our own little audit tool, which I think is very similar to the Hot North tool, and worked well with our electronic medical record system and the data we were able to get from there. This year we completed the audit with the assistance of some two medical students from the University of Notre Dame, and we looked at two of our remote clinic sites. We completed an audit of around 50 to 60 prescriptions at each site, and they were randomly selected over a period of about a month. And the idea for us is to develop an audit cycle where we can regularly audit our prescriptions in clinics and provide regular feedback to our prescribers, so that we can improve our stewardship and reduce resistance. So that's the goal. The audit this year, we reported back to our prescribers at each clinic. So at the clinic level, we reported the percentage of adherence to guidelines. And as Asha spoke about before, we use Kimberley guidelines, which are produced by the Kimberley Aboriginal Health Planning Forum. And they're locally developed evidence-based guidelines that are adapted to our context in the Kimberley. If there's not an available guideline from the CARF, we then look at therapeutic guidelines or CARPA. We also reported appropriateness of prescriptions according to the NAPS definitions, and this was really important, and you know, it's been spoken about already in this webinar quite a lot due to the factors of remoteness. We have limited access to diagnostic facilities, a big reliance on a frequently changing and fly-in fly-out workforce, and also a lot of aeromedical or road evacuations. So there are lots of factors that do contribute to prescribers' decisions when they are treating infectious diseases. So we looked at the appropriateness of the prescriptions, not just the complete adherence to guidelines. We also provided prescribers with 3 actionable key messages from the result of the audit to serve as good reminders about education, and I'll go through some of the ones we shared earlier this year a little bit later. And as I said, the audit cycle, the plan is to encourage continuous quality improvement in the area of antimicrobial stewardship within our organisation. Go to the next slide, Asha. This is a slide that's just straight from the audit, and I think it reflects what everyone has already spoken about, the heavy burden of skin and soft tissue infections in our communities. So this was one of the clinic sites, and both were quite similar, but out of all of the prescriptions, 47% were for skin and soft tissue infections. Next slide, please. So these are our initial findings this year, and obviously it was a small sample size and just the 2 clinic sites. I think the main thing to take away from this is that our appropriate prescriptions were, the percentage was a lot higher than the adherence to guidelines, but we identified a few reasons why the adherence to guidelines percentage was a bit lower than appropriateness, and I'll show you on the next slide. I think one of the big differences we noticed in doing this audit is the difference between, say, a tertiary hospital audit and an audit in primary care. We're not auditing a med chart, we're auditing a clinical medical record, and sometimes all of the dosing parameters or the prescription parameters weren't included in the medical record, and most commonly the duration sometimes wasn't documented, and for those reasons, we only considered a prescription adherent if everything was documented and everything was correct. So that's some feedback we've provided to our clinics, and documentation is really key because of our changing workforce and our changing staff in our clinics. So that was an important piece of feedback, and hopefully we'll see an improvement in adherence, also, because of our antimicrobial stewardship, and also because our documentation will improve. So the last slide there for me. So these are some of the key messages we shared with our prescribers. So of course about ensuring that the medication dose, frequency and duration are all documented well in the medical record. Reminders to look at our guidelines, particularly the CARF clinical guidelines, which are available easily on the web. And also some disease-specific feedback that was directly from what we found in the audit. For example, in the management of conjunctivitis, to always think about the cause of it. A lot of conjunctivitis is viral and self-limiting, and providing some instructions for our clinicians in treating conjunctivitis, which can be difficult and confusing, especially in areas where we have endemic trachoma. And also about gonorrhea, reminding people about these management of these diseases, for instance, gonorrhea, which requires dual antibiotics to prevent resistance. And up here we use Zapax, I'm sure across most of the north, or ceftriaxone and azithromycin. So that's sort of the feedback we provided to our clinicians, and we look forward here at KAMS to be part of the academy and to be able to resource our Aboriginal health practitioners to be involved in antimicrobial stewardship into the future. Thanks, Asha.
Thanks, Caitlyn. That was a wonderful example of, I guess, what we hope to achieve with the Antimicrobial Academy. So something that's already in play, and that we hope to continuously encourage more people to be participating in this. So essentially, this is my shout out to everyone listening in today to share this information and think about if there's anyone in your workforce, in your work world, who might be able to participate in this Antimicrobial Academy. So it's a 9-month program, and we've got funding now for 12 Aboriginal or Torres Strait Islander healthcare workers, pharmacists, doctors, nurses, Aboriginal health practitioners who are embedded in clinical care in the north, who are interested in upskilling in antibiotic use, audit, stewardship, surveillance and resistance. So it's going to be, I guess, an exciting time, and obviously we want to premise that our preference is for Aboriginal or Torres Strait Islander healthcare workers from the north to participate, but we would welcome applications from Aboriginal Torres Strait Islander people around, I guess, the country if they're interested in participating, because we just are not exactly sure how big the need is for this, and applications will help drive that, as well as those who are not First Nations but working in a remote or rural Aboriginal primary care facility who are really interested in achieving some of these goals. And so it is prioritised towards First Nations, but we would welcome those applications as well. So further details about the Antimicrobial Academy are available on the Hot North website, and the web address is provided there, with submissions closing on Monday the 14th of December, so about 3 weeks from now. It's a very simple application process, and all of the information is on the Hot North website. So the aims of the Academy are to train in performing antimicrobial stewardship audits, to use the surveillance skills to collect, understand and utilise antimicrobial resistance data, and really at that local level to develop things like the key messages that Caitlyn was talking about. And it was a beautiful example of some of the work that we would like to promote to have happening in the remote sector, much more so than has previously been the case, and is actually growing as we speak. So there's audits popping up in lots of different places already, and we're hoping to continue to promote that. And ultimately, thinking about the National AMR strategy, which we'll talk a lot about later, but really advocating for the antibiotic resistance issues that are affecting First Nations people, particularly in rural and remote areas, to really be positioned well and identified and addressed in the National AMR strategy in future editions, because they're not there at the moment. So the Academy will look like monthly lectures and workshops via Zoom that will be led by the Academy faculty. And there's a range of faculty from around Australia who will be delivering these lectures. And really asking simple questions about what is antimicrobial resistance, audit, stewardship, to make sure that we're all on the same page and understand the core principles, and use case-based discussions to guide that. And at the start of the year, we met together in Brisbane, and we didn't think that a Zoom function would work particularly well for the first meeting, but I think we've all learned very effectively this year how to use Zoom for training and for connection purposes. And so that will be the major method for lectures and workshops. Hotspots will also be used, and then I guess understanding antibiotic guidelines. There will be a 2-day full day workshop in Darwin, we hope, pending borders, COVID, everything else that's changed our world this year. And really with project work similar to what Caitlyn demonstrated at the Primary Healthcare Centre throughout the year with a mentor or supervisor located elsewhere. So we will evaluate the Academy with a pre and post Academy knowledge, attitudes and practices survey of all of the participants as well as the faculty, and we'll record the lectures and workshops for future use, such that it will be, I guess, a package that could be continued to be accessed in the future should the need continue, or can be modified and improved for future use. And also, I guess, continue to look at methods for both advocacy as well as publications of the audit results, such that the full picture of antimicrobial use and antimicrobial resistance that impacts the northern parts of Australia is really, I guess, identified. And so this is, I guess, an example. We've talked a lot about MRSA, but I'm thinking about we're able to track the amount of bacteria being, I guess, identified. We're able to track resistance. And so now we really need to map and match that resistance profile that we know is a big one to the antibiotic selection and choices, and really think about if we're losing antibiotics because of resistance generating so rapidly, what are the decisions that need to be made from a guideline perspective and an advocacy perspective to change that. So this is work that was done in WA by Simone Tampone and Amy Burrows several years ago, but confirms just that very, very high burden both of hospitalisation as well as MRSA for remote living Aboriginal people. So this is the last slide, and everyone's very welcome to take photos to remember the details, but the Antimicrobial Academy for 2021 will be starting in February, and submissions to participate in the Academy close on Monday the 14th of December. So we would really welcome lots and lots of applications. We'd welcome you sharing this, putting it up in different places where you might think that someone in your world might be interested in participating. It won't be a heavy time commitment, but it will be a commitment to a couple of hours a month to participate in the Academy. So there may be time later for questions on it, but I'm going to stop my share so we can move to the next talk as well.
Thanks, Asha and Caitlyn. That was excellent, and I think a really great platform for some of the discussions we're going to have during the panel session. So we'll move on to our next speaker. Next, we'll hear from Dr. Sonali Coulter on national surveillance systems, surveillance programs. Sonali Coulter is the data manager for the Queensland Health Surveillance databases for antimicrobial resistance and usage, called AugTrax and MetTrax. She has over 20 years experience as a microbiologist scientist and also holds a PhD in antimicrobial stewardship and health economics. Welcome, Sonali.
Thanks, Teresa. Look, I just want to, in this session, present an overview on how Queensland Health applications contribute to the program. So I'll just start my slideshow. Okay, so the databases that are managed by Queensland Health that report to the AURA program, the first one is ORGTRAX, and that database captures laboratory information system data from a number of laboratory information systems from Queensland Health down to New South Wales, Victoria, Western Australia, Tasmania, and South Australia. So this data is captured in the ORGTRAX database, and it feeds into the Australian passive AMR surveillance system that's managed by the Australian Commission for Safety and Quality in Healthcare. And then that data basically feeds into the AURA. So that's pretty much how the database feeds into national surveillance. But in Queensland Health, we also have a MedTrax database that collects antibiotic use data. And this information is captured from iPharmacy systems across Queensland Health in public facilities. So this data comes into MedTrax, and this is where the data is accessed by antimicrobial stewardship pharmacists. This information gets reported into North. And then again, all of that data is captured in the National Health Program. So I'd like to just focus on ORGTRAX and antimicrobial resistance to start with. So as we all know, the quality of the data is pretty important, and data quality in this setting really relies on the testing and interpretation of the results. So there are some variations between the contributing sites, namely testing methods used, quality of the testing, checks and balances, the interpretation of the results, so which guidelines are used for the interpretation. And I think one of the very important aspects is the training of the scientific staff. So access to good, consistent training is keeping standard and meaningful. So at the moment, the Australian Commission for Safety and Quality in Healthcare manage participation to APAS, and we have good representation from Queensland Health and ACT. Victoria, there's only Monash Health that contributes at this point. South Australia, we've captured nearly all their public hospitals, Path West the same, and New South Wales Health Pathology Service also contributes to APAS. We've only got a small representation of community sort of pathology, I guess, because there's not many private pathologies contributing to APAS as yet. Sullivan Nicolaides from Queensland basically captures their data and sends it directly to AURA, and it's not part of the ORGTRAX database. So we're hoping that we can engage more participants to increase the cross-sectional aspect of the data that we capture in ORGTRAX. So we have ORGTRAX at this point, just looking at data between 2015 and 2020 up to now. We've got a great representation of data from Queensland. So Queensland Health and MARTA, the 35% of the data is from there, 27% from New South Wales, 17% from WA, 13% from South Australia, but only a small representation of Victoria data. So we're hoping to sort of improve on that in the next year. And just out of interest with regard to remoteness and what sort of areas the data is coming from, if you look at the national data, just for 2019, you can see that the majority of the data is from major cities and inner regional Australia. Outer regional 40%, and here remote and very remote is only 10%. And here the 15% of the data that we don't have information on is really from New South Wales, and there's health pathology. So there that we can capture for those that 10%. But looking at Queensland data, you can see here 54% of the data is from major cities, 21% from inner regional, 18% from outer regional, and it's only 7% that represents remote and very remote Australia. So org track ability specific antibiogram, but it's also useful to look at susceptibility trends and graphing, drilling through to the source data. If you look at an unusual susceptibility that you want to see a bit more information on. Also, profile reports are quite useful for epidemiological purposes. And we have a Geo-analytics program or workboard that we can use. This is based on the patient's postcode. So, depending on the size of the facility, you know, if you have greater isolate for a statistically meaningful susceptibility, but smaller hospital data can be pooled to create antibiograms. And recently, this is the data cube that the data resides in, and you can slice and dice the data as you wish. And it's very much like a very large pivot table. So here, I haven't captured all of it, so you won't be able to see everything there. But that's a cumulative antibiogram. But we've recently been able to develop a workboard that actually displays the antibiograms in the way that most clinical microbiologists like to present the data. And that's been a great achievement. So it's kind of color-coded to represent groups of susceptibilities. And certainly the Pathology Queensland clinical microbiologist is very excited about this view because they don't have to manually create this view in Excel. Looking at susceptibility trend and graphing, here's an example of what you can do in org tracks. This is Chemioxone and E. coli just over time. So you can look at your data, you know, the susceptibility reducing from, let's say, 98% in 2006 down to 91% in 2020. So you can play with the data and look at different drug combinations that interest you. Drilling through to source data is also quite useful. That went too quick. Through source data, and you're interested in seeing ESBL producers, you right-click on the count, and then you get the option to drill through, and you can then look at the different fields. I don't know what's going on here. The different pointers you might like to do during further evaluation. So here you can then get a CSV file with all of the information for those isolates that you were interested in, and you can then have a look at it and analyze the data. There's also a profile report which I find quite useful. If you're looking at MSA isolates, you can on the profile report, and what it does is it provides you with this sort of profile of your susceptibility at the top here. So if you're sort of seeing recently that there have been an isolate, a few isolates being coming through that have a specific resistance, click on the right little arrow here and expand that view, more detail on those isolates that have a specific view. So it just is kind of interesting little epidemiological tool if you wish to use it. Our Geo-analytics is again based on patient postcodes. So this is E. coli and class. And specific regions, you can map it on your state or on the whole sort of country. So depending on what you want to look at, you usually click on all of New South Wales if you want to, and the susceptibility of that data. So just want to quickly go through the MedTrack database. Is we start from iPharmacy into the MedTrack's data cube, and then we import WHO ATCDDs as well as accreditations into that database, and perform a calculation so that we can then calculate defined daily doses per 1,000 bed days for all Queensland facilities. And this is particularly of value, because this looks at all facilities and facilities that are large enough to contribute to North. So, you know, the remote and regional areas, Trent have been able to look at antibiotic usage in those sort of settings, which has been quite interesting. So also provide views for AMS pharmacists to easily pull out their midnight occupancy data and usage in quantities to then submit to North. And that's been quite helpful as well. It's a standardized way of pulling out the data. So again, just like org track data, got to be mindful of the source of the data and also the systems and processes within central pharmacy and hospital pharmacies. So for an example, central pharmacy, we discovered we're distributing direct award transactions directly to wards bypassing the hospital pharmacy. So some facilities, we were not capturing all of their usage because we were missing out on these direct award transactions. So it was a matter of actually looking at what was being captured into that particular facility. And also looking at the smaller hospital pharmacies and understanding how their stock is distributed to remote and regional areas as well. And of course, you know, the data is only as good as the accuracy of the data that's entered into iPharmacy. So for reporting, you know, submitting to North has been a really valuable reporting system of AMS pharmacists. We're also able to look at usage and trends in all facilities, and we can also drill through to the source data like we did in org tracks. So submitting to North, we're able to create boards that now can sort of pull out data in the format that North required, and AMS pharmacists can go into MedTracks and pull in their data the way they need it. And usage trends and graphing. So here, there are some common workboards that people like to use, and this is intensive care usage versus non-ICU usage. And this is for beta-lactam antibacterials. So you can select different graphs that, you know, answer the questions that you need to have answered. We seem to look at how we can display IV and oral antibiotic usage, and we developed this workboard then displays, say, for example, flucloxacillin with broken down into DDDs per 1,000 IV and oral usage. And you can present this information in any format you wish to, so graphs. So you can choose what sort of display the data in the best view. And we also developed this graph, which I can find is facility usage, the rolling average over 12 months. And the statewide average is the purple line. So it's just a comparative look at your facility usage, and this is the upper and lower limits of usage. And drilling through to the raw data is also quite useful, because if there are inventory sort of quantities that you think, look, that doesn't look right, you can actually drill through to the data, clicking into your iPharmacy transaction details, so you can actually validate and verify the data, which is quite useful. So in recent times, Trent Yarwood's team and the DSS team have coming up with a dashboard. So this is is something that's just in development, and this can then be accessed via a link. And this is useful for busy clinicians that don't have a lot of time sometimes to sort of, click into different systems and pull out data. So we're certainly looking forward to working with Trent and his team to develop this workboard. So just quickly looking at the gaps in surveillance, as I see it, certainly remote and regional Australia, we don't have enough data, and I think that's mainly due to laboratory capacity strengthening in terms of, having access to labs and courier services. Also, training and supervision of remote and regional laboratories can be difficult. And of course, standardization of the laboratory would allow for more meaningful comparisons. So I think, it's really hard to compare things if they're not the same sort of testing methodology. And while APAS is voluntary participation, it'll be great if we can get encouragement to sort of have more private laboratories participate so that we can get a better picture of community data for antimicrobial resistance. And look, over the last few years, I've been doing a lot of this, drilling and dicing and trying to figure out what it all means. So I'm going to leave you with that. And I'd like to also acknowledge the team at eHealth Queensland, their support services in housing the applications, and the Commission and the Prevention Division of Queensland for all their support. And that's it.
Thank you, Sonali. I think this is an excellent segue to our next presentation, where myself and Will Cunningham, who has actually already featured in some of these presentations before, some of his work has already featured in some of these presentations. So Will is a final year PhD student working in Darwin, based at Menzies School of Health Research. He has a background in epidemiology and also is the data manager for the recently established hotspot surveillance system, which is the one that we'll be talking about today. Will, can we slide share, please? Excellent. So I suppose we've all provided a little bit of background about inspiration of this various bodies of work that we've been talking about. My inspiration really came to improve antimicrobial resistance really came from work that I had done previously on trying to measure the health and economic burden in AMR. And actually some of the work that I when Sonali was doing her PhD as well. And what it became really apparent was the limited data that we have on resistance, not to mention morbidity or mortality and cost, which is essentially what I was trying to determine. So even more so was the fact that data that we had was largely from metropolitan areas, and a lot of that hasn't changed by the looks of what some of Sonali's presentations. So really, regional and rural Australia data was quite underrepresented. Meanwhile, single studies were reporting exceedingly high rates of skin infections and some of the MRSA that we discussed earlier. So wanting to improve our understanding of the burden of antimicrobial resistance really became quite a passion of mine, and I suppose moving to Darwin and being part of the Hot North program was really an opportunity to be able to develop that. Next slide, please. Thanks. And I think some of the challenges for antimicrobial resistance surveillance are not necessarily unique to just to this region, and I've listed 4 there, which describe some of the limitations of reporting. You know, the map here that you can see shows some of the regions that the national surveillance system captures, but it's quite obvious that there's this large geographical region that isn't captured in a lot of the national programs. So we are limited in the way we report AMR data. There's a lack of data standardization. Again, Sonali touched on this. Surveillance data are held in silos, so often the primary health AMR data is held separate to what's happening in the hospitals, and it's clearly a link between those two, and they should be shared. And therefore, the data is quite limited in how it is shared. But I suppose, importantly, what this means for surveillance is that there is a gross underrepresentation of regional and rural areas. And combined with some of the challenges that we described in the earlier sessions, this really contributes to the burden of AMR because we actually don't know what is happening in that region. So it's essentially a surveillance blind spot. Next slide, please. So trying to fill that blind spot, we got together quite an extensive advisory committee and with lots of key stakeholders who included pathology providers, data end users, data custodians, really an amazing group of people that through their goodwill all wanted to contribute to this project. And what we developed is a tool that delivered, that aims to deliver AMR data to those who need to use it. So we wanted to improve surveillance so that essentially it could be used for action by those who need to know. And Laura and Amy in the next session will describe a little bit about who those people are that need to know. So the end product essentially is a soon to be released upgraded version of Hotspots. We had an earlier platform that has now been upgraded to have more interesting functionality and more sophisticated functionality. And this new Hotspots tool will visualize AMR surveillance data every 6 months. Will is going to now, for the first time, show us a live demonstration of this platform, as well as provide a little bit of extra detail about the data that it contains. Over to you, Will.
Thanks very much, Teresa. Hopefully everyone can hear me. I'll just continue talking unless someone says otherwise. So I guess first I should acknowledge I'm over in Darwin on Larrakia land. I want to acknowledge the traditional owners. And before I show the Hotspots website, I'm going to just quickly go over a bit of the background of the data that are included in Hotspots. So as Teresa mentioned, it's focusing on the northern part of Australia, which we've come to roughly define as anything above the Tropic of Capricorn. We also do have some data from one of our pathology providers, Western Diagnostic Pathology, that provides data on the rest of WA down to Perth. So these regions are based on Statistical Area 3 classification from the Australian Bureau of Statistics. WA, Pilbara and Kimberley region, the entire NT, and everything above Mackay in far north Queensland. So in Western Australia, so we've got 4 pathology services overall. In Western Australia, it's Path West and Western Diagnostic Pathology. Western Diagnostic Pathology provides isolates from community healthcare facilities and is one of our biggest data sets. We've got data from over a decade worth of data, and they also provide data for community isolates in the NT as well. The hospitals in the NT are all 5 public hospitals are covered by territory pathology, from which we have data for the last 5 or so years, 2012 to 2017. And in Queensland, far north Queensland, we've got data from Pathology Queensland, which cover all the public hospitals and also some community healthcare facilities. And again, this is quite a large data set of over a decade. Most of the specimens that we have in our data set can be classified into these 4 specimen types: skin and soft tissue, urinary, respiratory, and blood. We focus on these 10 or so bacteria, and these are the antibiotics that we have susceptibility data on. Not every bacteria is tested against each of these antibiotics. It's just these are the total possible combinations that we have. To give you an idea of the size of the data set, the number of isolates we have, that Western Diagnostic Pathology data set, which is quite large, covering community isolates in WA and NT, is as I said, it's one of our biggest data sets. This number in WA includes down to Perth, so there's just a fraction of that is in Kimberley and Pilbara. The NT hospitals are completely covered by territory pathology, and in Queensland, most of the data is from public hospitals, but we also have a substantial amount of community data. And most of our isolates are, I mean, there are many different types of isolates, but a large majority of them are skin and soft tissue specimens or urinary specimens. So just to, this diagram gives you an idea of the entire data flow from when we receive the data to eventually getting imported into the website. So we got these data sets from each of these 4 pathology labs. They come in varying formats, so we clean them separately and then combine them later. They come in mainly Excel files, and we use Stata, the statistical program Stata, to clean and merge them. We apply susceptibility breakpoints definitions if they're not already interpreted. Most of them are interpreted data. We format and standardize the data format so that they can be combined, deduplicate isolates, just keeping the first isolate per individual per year, and group on other important fields like the region, the facility type, hospital, community, the organism, and the antibiotic. So then they're all combined into this final data set, which I keep separate as one by month and also one by year. So that did that so we could have the data set by year, also stratified by age group and sex. And so these final data sets are then imported to R, statistical program R, where the package, the Shiny package, is used to create an interactive website, the front end of hotspots. And the idea is that this will all be updated 6 monthly, receiving new data from each of the pathologies every 6 months. So I'm going to try and show the website now. Just keep in mind that this is, as Teresa said, it's not completely finished. It's still under development. So there are a few areas that still are being finished. Just bear with me while I get this view share. Okay, hopefully everyone can see website now. Let me know, I'll continue, but let me know if you can't see that. So this is the landing page. This is the first page that you'll see to the Hotspots website. You can see there are tabs across the top here. Currently we're on the map tab, these other tabs later. There's a little bit of information on the data that's included, just broad summary statistics. And you'll notice that there's colors in this map. I've just pre-selected, loaded this so I didn't have to wait for it to load or any issues with loading. It only takes a few seconds, but just to avoid any potential issues. So this will actually be blank when you first come to the website. And as designed, the set out of this is designed so that you come over to the left and start at the top and select the questions that you're interested in. So first you'd select, well, we only have data on human at the moment, but there's potential to include animal data at a later stage. So you'd select human, whether you're interested in hospital or community isolates. For now, leaving it as overall. So that's everything combined. You then select the sample type, the specimen type that you're interested in, blood, respiratory, skin, soft tissue, urine. Again, just keeping with all to show you the most amount of data. Select the organism that you'd like, going with E. coli, and the antibiotic that you want to see susceptibility proportions to. Then you select the the map tab is only going to show you 1 year, so you select a single year. We are working on potentially including a functionality to have a year range where it would average over a certain number of years, but for now it's just a single year. Then you load the map. It might take a few seconds, and you can, and then you'll actually see this load, and you have the option to change the color palette to a color-blind friendly color palette. And so this nice map appears, and you can immediately get a sense with minimal effort to compare the resistance proportions across a large region, and between these regions and between jurisdictions. And if you want to see the exact percentage resistant, you can click on the regions, which will come up with the percentage resistant and the number of isolates that were tested in that particular year for this combination of specifications. So that's the map tab. Another tab up the top called plots, which also has sub-tabs that allow you to look at the data in various ways, by region, by antibiotic, sample type, age, sex, and month. Again, this is preloaded. It will be empty when you first go to it. So you, again, follow the same method. You'd select what kind of data you want. Human, here it's human overall, same as before, E. coli, cavazolin, and you select the regions you want to compare. Remember, this is the by region tab. And the bar chart, the x-axis being by year. So you can compare by region and also over time. And again, it will only show data for which we actually have data. The by antibiotic lets you compare resistance proportions by antibiotic. Again, showing the similar specifications as we had before, and select which antibiotics you want to compare, add or remove any of these, and it comes with this dot plot as well as a bar chart for over time. Again, the x-axis being over time. The by sample tab is one of those tabs that are still under development, so I'll skip over that. Go to the by age tab, which stratifies the data by these age groups. And this part of the data set is quite special, I think, that to have age and sex to be able to group by these is quite powerful. And you can see trends over time as well as by age group and by sex. Blue being male for this, and red female, and an average in grey. Again, over time, over year. And finally, by month instead of by year, this gives you a bit more of a granular view in terms of time trends, and also potentially look at seasonality if you were interested in that. And down the bottom here is a bar chart showing the denominator in each of these monthly proportions, the number of isolates that were tested. So I'll move on to the next tab, which is antibiogram, creates antibiograms, which isn't really something new for hospitals, although our data might be updated more quickly than the hospital antibiograms. But specifically, we will create antibiograms for community isolates. Again, this is pre-selected, so it's already loaded, looking at specifically at Townsville in 2017, and it will load automatically this antibiogram showing percentage susceptible. Actually, it's as you would see in a hospital antibiogram. And it's also got options here to export in various formats in case you'd like to share that with any colleagues. Sorry, I'm zooming through this. I can come back to anything if anyone would like. The data and methods tab goes through the details of how we'd like to use the data and the methodology at the bottom. And it also provides the option for you to download any of the aggregated data, not the individual level data, but the aggregated data on specific, whatever you're interested in, download it out to Excel and analyze it if in any way you would like to. and that's also available as yearly or monthly data. The economic burden tab is still in development. We'll look at a calculator of the cost of various resistant infections. There's other information involved in this information tab, and eventually we'll be able to share it over various social media platforms. So that's a very quick snapshot of this hotspot tool, which has taken a lot of time to put together, and it's looking pretty good, I think. But it is still under development, and possibly, I think Teresa mentioned, it will be possibly launched later this year. So it's very close to be finished. Just a few things extra to finish off. So that's all from me. I'm just going to share back the slides. Sorry.
Thanks, Will. That's excellent.
There
And great that it all worked out. Live demonstration.
Yes. Okay. Here we go.
Fabulous. Thank you. So I suppose being a ultimate optimist, I always think every challenge can be turned around to an opportunity. So back to those 4 challenges that we discussed earlier, I suppose they can now, with some of the work that Will has just described, can be turned into an opportunity. And we're hoping that the hotspots surveillance system and the program of work that we're developing will allow us to finally have timely and accurate reporting of key AMR data from a region that has previously been underrepresented. We're looking to have 6 monthly data updates from each of the 4 pathologies that we currently have on board, and we are looking to extend the pathologies that come on board to the program. Like Will mentioned, the community antibiogram is a first-time feature for some of the community data, so that's quite exciting. I think the hospital antibiogram is probably less interesting, but nonetheless, the features of a customized report is of interest to both hospital and community clinics. And those reports will be able to provide susceptibility patterns by region, by jurisdiction, between jurisdictions, within jurisdictions, by age, sex, and all the other things that Will had mentioned. In terms of data standardization, we've developed protocols for how we aggregate the data, analyze and report it, and what's the best way to facilitate easy data extraction from the pathology providers who are already overburdened with a lot of work. This is not about increasing their workload. If anything, it's to reduce or facilitate some of the other things that they have to do. In terms of surveillance data now, we find with hotspots we are able to produce essentially data from community and hospital in one platform. So we're consolidating a lot of the work that has gone into this, and it's a real opportunity to be able to feature the work from the different sectors. So we are sharing data. We've essentially shown proof of concept of being able to share pathology data across jurisdictions and across sectors, which has been kind of exciting. We have the pathology providers as part of our advisory committee, and we're constantly asking for feedback and advice how to make this a tool that is useful not only for clinicians and AMS pharmacists, but just as much for pathology providers, who are actually the people that are supplying the important data and obviously a key stakeholder. And we're wanting to ultimately for this local data to be used by local practitioners and to be able to be used to update local guidelines and national therapeutic guidelines. Next slide, please. So as a final acknowledgement, this has been a lot of work and a lot of people contributing a lot of their goodwill. Like I said, the Hotspots Advisory Committee that includes the 4 main pathology providers, Pathwest, Western Diagnostics, Territory Pathology, Pathology Queensland, as well as other key stakeholders. This program was funded by NHMRC funded Hot North program. My current employment is funded through the Australian Partnership for Preparedness Research of Infectious Disease Emergencies, their Prize Fellowship. And we need to acknowledge as well the data scientists behind this new upgraded tool. Alice Young, who's starting her PhD soon in Northern Australia as an amazing data scientist, along with Dr. Saras Windaker and Dr. Nick Golding from University of Melbourne. Laura Goddard and Amy Legg, who are up next, did a lot of the work around evaluation and implementation, and that all of that work has really contributed to the way that this platform is currently looking. So thank you. Great. Next up are Laura and Amy, who are sharing an office. Wonderful. Laura is an epidemiologist and a registered nurse. She's currently completing her Masters of Applied Epidemiology. She's placed within Northern Territory Primary Health Network and Menzies School of Health Research. The next speaker is Amy Legg. She is probably familiar to some of you. She's now living in the Northern Territory, but used to be a Queenslander. She's an antimicrobial stewardship pharmacist from Top End Health Service. She's passionate about ensuring patients with infections get treated with optimal antibiotic treatment. Excellent to have you on board. Amy has experience in both national and local guideline development and implementation, research projects, and in education. And she recently started a PhD looking into nephrotoxicity with common antibiotic combinations. Over to you guys.
Okay, thanks for the introduction, Teresa. I'll just pull up our slides. While Laura's doing that, first of all, happy Antimicrobial Awareness Week to everyone. And we also want to pay our respects to the traditional owners of the land where we are meeting today. We're on Larrakia land, and we pay our respects to elders of the community and those emerging leaders as well.
Great. Thanks. So as we've heard, surveillance is essential to all aspects of AMR prevention and control because it provides the evidence to support clinical and public health decision making. And Teresa and Will have talked a bit about hotspots and how that was developed in response to really a lack of AMR surveillance data from regional and remote areas in Australia. And the need to provide data directly to the end users of that data. So to know whether hotspots is achieving these aims, we've conducted an evaluation, which I'll be speaking to, and the evaluation recommendations, how these will be used to inform how hotspots is used in practice, is what Amy will be covering shortly. Okay, so the aims of the evaluation were to describe and analyse the utility of hotspots to end users and to make recommendations to improve its ability to support clinical and public health decision making. And when I'm describing end users, I'm talking about antibiotic prescribers and drug administrators, which is really a bit of an umbrella term to cover doctors, nurses, Aboriginal health practitioners and pharmacists. As well as scientists and microbiologists, communicable disease, surveillance and control professionals, policymakers, and content experts, bit of a mouthful, who contribute to treatment guidelines. In terms of the methods, we've used an evaluation framework, which is the US CDC guidelines for evaluating a public health surveillance system, and people who are familiar with that framework will know that there's 9 surveillance system attributes against which you assess the system's utility. We collected qualitative and analysed quantitative data to measure those attributes. So in terms of qualitative data, I conducted interviews with the aforementioned end users and audio recorded, transcribed, and then manually coded those against the CDC attributes. And in terms of quantitative data, I did a descriptive analysis of the lab data that is contributed to hotspots, as well as an audit of hotspots data against available antimicrobial susceptibility data from NT hospital antibiograms. I won't go into this slide in detail, but it's there for reference if people want to look at it later. But essentially in the left-hand column is the 9 surveillance system attributes, which I mentioned. So I'll talk about those a little bit more in the results section. In terms of results, we invited 23 end users to participate and 19 consented, so it was a response rate of over 80%. I conducted 11 one-on-one interviews and 2 focus group discussions, and the final participants included 2 laboratory scientists, 3 treatment guideline content experts, 4 antibiotic prescribers, 11 public health professionals, and 1 policymaker. And looking at the results of the individual surveillance system attributes now, data quality refers to the completeness and validity of the data recorded in the surveillance system. So Will already described a little bit about the data that's collected from the 4 pathology service providers. This includes microbiological data and some demographic data. So the descriptive analysis that I performed found that this was pretty complete, but there were some variations in the data provided. That is in part due to different antimicrobial susceptibility testing guidelines used between jurisdictions. So for example, some providers may give results that are susceptible, intermediate and resistant, or they could also provide that as just susceptible or resistant. And a sub-analysis of hotspots data against NT hospital antibiogram data, looking specifically at Staph aureus blood isolates for 2017, found pretty good agreement between the 2 data sources, so that gives a good indication of the system's sensitivity and the data completeness as well. In terms of acceptability, which is another one of the surveillance system attributes, and acceptability refers to willingness of end users to engage with or participate in the system. Just got a couple of quotes up there taken from interviews. And the first quote really illustrates that doctors working in, this was in a primary healthcare setting, found that having population level rates of resistance and knowing that what changes are occurring over time would be quite helpful. And the second quote is really showing that there's still maybe a little bit of hesitation or concern over how hotspots will influence practice, and just that's a concern that some end users have. In terms of timeliness, which is defined as the time between the production of data to the point at which information is made available to end users, pretty much all end users were very pleased with 4 to sort of 6 monthly data updates, particularly in the context that antibiograms are made available annually or sometimes less frequently. So both of those quotes there just highlighting that. And then finally, in terms of representativeness, which is the system's accuracy in describing the occurrence of the disease over time or distribution in the population by person and place. Again, we've got data in hotspots from the 4 main pathology providers in the region. There are 7 pathology service providers, but some of these are quite small. For example, Australian Clinical Labs just has 1 small lab here in Darwin that services the private hospital, and some of that some of the AST testing is actually done at territory pathology anyway. So having those 4 main providers across Northern Australia who service both community and hospital settings means that the geographic representativeness of hotspots is very good. There are some limitations in terms of being able to describe the occurrence of AMR among the population by person, and that's largely because it is laboratory data. So we have age and sex, but for example, Indigenous status isn't captured through laboratory data. So in summary, hotspots data provides timely geographically representative and good quality data directly to end users. And the ability of hotspots to inform clinical and public health decision-making could be best improved by greater data standardisation, collecting or linking to clinical and epidemiological data, and working with end users to address any concerns regarding impact on clinical practice. So I'll hand over to Amy now to continue.
Thanks, Laura. So just getting our heads around all of this. So we've seen the wonderful tool that Will presented and Teresa spoke about, and then Laura's done the evaluation, and now I guess it's time to take it to the streets. And antimicrobial stewardship is all about taking infectious diseases to the streets, to the people who are going to use it. So I'm just going to talk a little bit about how we're planning on taking hotspots and getting it to the users. And a lot of that will be similar things that other people have already mentioned. So bear with me a little bit. But I guess in terms of implementation strategies, we've identified a few key organisations, particularly in the primary health setting. And what we're aiming to do is meet with the organisational leadership of some of those groups, and I'll talk about those in the next slide. And really, starting with that stakeholder engagement and making sure that something like hotspots will fit within their model of care, and that the governance structures know how to disseminate it throughout their workforce to make sure we have a coordinated approach to its use. We obviously want to do a lot of education, both on the tool and how to use it, but I guess it's a great opportunity to piggyback key messages about antimicrobial resistance and antimicrobial stewardship and how they link, while also providing people the information that they'll need to know to use the tool. We also want to make sure that prescribers or the end users essentially are going to have easy access to this information. So up here in the Northern Territory, we have an app called Teams, which gives people antimicrobial codes to use for some of their restricted antibiotics. So we'll be embedding hotspots, links to hotspots in there. And also we'll want to try and make sure as much as possible we're in appropriate GP software for people who are going to be using it, and making sure that the information is easy to get to. And we also really want to link in with guidelines. So I think we want to make sure that the guidelines and the information from hotspots support each other and can both work together. So certainly there's some opportunities really for the hotspots data to drive recommendations in guidelines, but also where there might be discrepancies, making sure that guidelines explain why and really support people to continue using hotspots in the most appropriate way. So in terms of some of the groups that we're thinking about, this is a little bit NT centric, sorry about that, but obviously this tool does go across the whole Northern Australia, and we do have links and great colleagues in Queensland, WA who have already presented today. So some of obviously what we're really providing opportunity to here is primary health physicians. And so some of the key groups that we're hoping to link in with are Danila Dilba, which is an Aboriginal community-controlled organisation that provides primary care to Aboriginal and Torres Strait Islander people across the Greater Darwin regions. They've got 8 clinics in sort of Darwin proper, and then down in Palmerston and even as far south as Humpty Doo. We also would like to link in with MeWatch, which is an independent Aboriginal controlled health service across East Arnhem Land. And just if you've never heard of MeWatch before, they have a really wonderful website which deals both with what they do, but also some amazing history of East Arnhem Land. And I have been really blown away by it. And so I just wanted to give that a bit of a plug. The other group is AMS-ANT, which is Aboriginal Medical Service across the NT. It's an affiliate of NACCHO and a peak body for Aboriginal community controlled health services across the NT. The CARPA working group, a lot of you again will be familiar with CARPA, the Central Australian Rural Practitioners Association that produced a standard treatment manual that's really the treatment Bible for community-based treatment in the Northern Territory. And of course the Northern Territory PHN, which is the not-for-profit commissioned by the Australian government that works closely with primary health sector to develop better coordination of care. And they also do a lot of work with the rural workforce, so recruiting and retaining staff, so another key sort of organisation for us. The other thing, particularly being the TES AMS pharmacist, obviously will be able to integrate with all the TES hospitals, and they'll be able to get some more specific data, even just for the tertiary hospitals. And also link in through the AMS jurisdictional network and the National AMS Committee with our colleagues in Northern Queensland and Northern WA. So just carrying on essentially from what Teresa and Laura have said, I think one of the really interesting things that is the next phase of the hotspots tool is what it looks like when it's going to be used in practice, and the implementation opportunities. Have I spelled implementation right? Anyway, it doesn't matter. Is, you know, a really exciting thing to be thinking about. So in terms of what the tool can add, you know, this is a really unique location that we're covering, it being, you know, across Northern Australia. There's a high turnover of staff. There's, you know, remote practice and high resistance rates. So I think it's a real opportunity to get a handle on what's happening in an area that, as other people have mentioned, we may not have previously had. It's really helpful for understanding background antimicrobial resistance rates, particularly if there's fly-in, fly-out doctors that want to be able to, or nursing staff that want to be able to have a look at what the background AMR is, you know, before they go into a shift in a new location. I think that's going to be really helpful if it's a bit more granular based on their specific location. One of the other things is that antimicrobial resistance, like a lot of the global threats, is largely invisible. And I think a tool like this really helps provide both a literal and figurative platform to talk about antimicrobial resistance. And as people can see the trends and changes in susceptibility patterns, it makes it so much more real. And again, based on some of the feedback that Laura got during the evaluation, you know, provides timely and direct access to region-specific data, regional-specific data that was previously unavailable. So I think there's a lot that the tool can add, and I don't think that anyone would you know, think anything different to that. But there are, of course, going to be gaps, and what we want is to, you know, meld with the vision for hotspots with the end users. So we will want to hear about its usefulness in practice, and we'll be doing a talk with the NT Primary Health Network on next Wednesday evening. Yes. Thank you. And so there'll be a lot of hopefully end users there, and even today, just to hear about where we think that this might fit into their workflow. Certainly one of the things we know is that there may be discrepancies between the data that's available in hotspots and what guidelines recommend. And certainly what hotspots is giving us is population-based data, and what we, you know, want prescribers to be able to do is to, you know, particularly be able to use that maybe in moments of therapeutic failure, or even, I mean, seeing the demographic data that Will was able to highlight. You know, we might be able to help people make more nuanced decisions, but I guess the, you know, the limitations of the hotspots tool is that it is population-based data, and we do still need clinicians to be making those patient-based decisions. Yeah, and so we're obviously not expecting this information to replace guidelines as the standard of care. The other gap is that only people who know about it can use it. So we are really trying to make sure we get the information to all the people who might want to use it. And it's a real opportunity to link AMI, like antimicrobial resistance data, potentially with clinical outcome data or antimicrobial usage data, and to look at how patients' lives are affected based on prescribing patterns or antimicrobial resistance. So I think to try and minimise the gaps, maximise the gains, feedback is crucial, and we just need to all work together, both the people who have designed it, the people who are implementing it, and the people who are using it. Thank you very much.
Okay. Thank you. Hand back over to you, Teresa.
Wonderful. Thank you, Laura. Thanks, Amy. I think you've raised a lot of really important and interesting points there, and as well the concept of this not being a replacement of treatment guidelines. I think it's important. Part of, I think Will did show on the presentation that part of in one of the sections we will be showing the guidelines, the CAPA guidelines and treatment and national treatment guidelines. So definitely, but you know, your work around advocacy and education will be really key in making sure that it is used appropriately and does not stray away from clinical guideline practice. Thank you.
Thank you.
So we're on to our last presenter before the panel discussion, and this I suppose some of the work that Karen will be presenting speaks a little bit to what Trent presented in the opening session today. So our speaker is Dr. Karen McCulloch from the Doherty Institute. Karen is a postdoctoral researcher who uses mathematical modelling to understand infectious disease dynamics, and has a particular interest in developing spatial models with applications to public health. And she's going to talk about some preliminary work that we've been working on, which is kind of exciting, looking at the social factors and social drivers of antimicrobial resistance. Over to you, Karen.
Thanks, Teresa. Okay, so I'd just like to start off by acknowledging the traditional owners of the lands on which we are all meeting today. So just a little bit of background. So in Australia, the observed low frequencies of antibiotic use and the high rates of community-acquired antimicrobial resistance in underprivileged areas supports the hypothesis that focusing our efforts on reducing antibiotic consumption alone will not be enough to effectively contain antimicrobial resistance. So for example, in the Northern Territory, we know this territory has some of the highest community AMR rates in Australia, even though there's evidence of using fewer prescriptions. So the aim of this pilot study is to take the first steps in determining if social factors are associated with increased prevalence of antimicrobial resistance in tropical northern Australia. So we're doing a retrospective data analysis using the hotspots surveillance dataset, and Will and Teresa gave a really nice introduction to the region we're looking at, and it's a really rich dataset, which is great. So the data that I've been using from the surveillance dataset is the number of susceptible and resistant test results of isolates from the community clinics during spanning the time period 2007 to 2019. So we use aggregated test results for each region of interest in tropical northern Australia. And these regions have been defined by the Australian Bureau of Statistics Statistical Area 3 boundaries. And the population sizes within those regions range from around 30,000 to 130,000 residents. So we're looking at quite high level data in this study. So in this analysis, we selected a number of organism and antibiotic combinations of interest to focus on. But for this presentation, I will focus on ceftriaxone-resistant E. coli and MRSA. So on the plot there, we've just got an illustration of the distribution of the proportion of tests that are resistant across the regions that we're focusing on. Okay, so what are we talking about when we say social factors? So each of the social factors which we considered were defined at the population level under the Australian Bureau of Statistics SA3 regions. So we look at the remoteness index, which is a categorical variable. We also look at the index of socioeconomic disadvantage, which is a measure of the relative social and economic disadvantage in regions. In addition to that, we look at the average persons per household for each region and the population density. So again, this slide here just shows how those factors are distributed across the regions that we're interested in. So what we do, we derived or performed a univariate and multivariable logistic regression to determine if any social factors are associated with the prevalence of AMR for the selected antibiotic and organism combinations. Okay, so this is just an example of some of the early results that we have got. So for both, what we're looking at here is the odds ratio. So I'll explain what these indicate to us. So for both MRSA, which is in the blue, and ceftriaxone resistant E. coli, which is in the red, we see that the odds of a resistant test result increase with the remoteness index, which aligns with what we know from other studies. For MRSA, the odds of a resistant test result decreases as the index of socioeconomic disadvantage increases. And what this indicates is that MRSA prevalence is higher in the most disadvantaged regions. But an interesting result that's come out of this is that for MRSA, the odds of a resistant test appear to decrease as the average persons per household increases. Whereas for ceftriaxone resistant E. coli, the odds increase with increased average persons per household in each region. Population density didn't seem to be highly associated one way or the other for both organisms. I'm just aware of the time, so I'll just say that these are sort of some example of results from an initial study that we have conducted to explore the association between social factors and AMR prevalence. And really just to reiterate that we think that the consideration of these types of factors may help us to understand why some areas in Australia have a low frequency of antibiotic use, but high rates of community-acquired AMR. And there's a number of different ways that we would like to improve upon this study, but I'll stop there. I'd just like to acknowledge Teresa and Will, who are both collaborators in this study. Thank you.
Thanks, Karen. Wonderful. So I think this brings us to the final session, which is the panel discussion, where it's really an opportunity to consider some of the work that that has been presented today, and to see how it could, or how we can work together to influence the national health agenda. And I suppose thinking about the second AMR strategy that has been recently released, you know, a lot of effort has already, Australia has committed quite a bit to containing antimicrobial resistance. And I think, you know, the establishment of the One Health AMR hub, the AURA report, that the AURA program that Sonali has mentioned, you know, and probably most relevant, the establishment of the GP expert group. They've all been really excellent initiatives, but there's clearly a lot of gaps. And I think, you know, Asha in particular is shaking her head. She's been thinking a lot about this, and I think, you know, making sure that regional and rural Australia, that Indigenous communities are part of the conversation is really important. Asha, what are your thoughts?
Thanks, Teresa. I do, AMR is on the national agenda. The thing that's missing, as we've identified, is the whole discussion we've had today about the huge burden and the underappreciation of it in rural and remote Australia. And so I think that if you Google the National AMR Strategy and read through it, if you try and search for remote, rural, primary healthcare is in there, but rural, First Nations, Indigenous, Aboriginal and Torres Strait Islander, it's just not there. And I feel as though this group who presented today, as well the group listening, now have, I think, some really significant resources and opportunities to continue to influence that. And so some of the things that I guess the way forward with that is that there's an implementation plan and progress report. And so there are 7 factors on that implementation plan and progress report that we can then start to map all of these activities against in order to inform and make sure that this is highly present in the next.
No, that's excellent. Trent, what are your thoughts?
Yeah, look, absolutely. I just want to echo what Asha has said. You know, those of us presenting and listening today have spent time working in rural and remote Australia, and we see what you know, what goes on in the hospitals that we look after. And you know, it's just really about getting the message out there, getting it to, you know, not, of course, not to say that people don't take rural and remote health seriously, but it's the issues really are different, and because of the burden of infection, drug resistance is going to affect people who live remotely differently than it affects people in the city. And, you know, we want it to be addressed because it's an important health issue, not just because, you know, people who are in small centres end up going to KAMS or to Broome or to Darwin, you know, they get evacuated. It's not only a big hospital problem because it eventually comes to the big hospitals. It's a problem for everybody right to start off with. And, you know, we know that the best way of approaching, you know, problems with Aboriginal and Torres Strait Islander health is community involvement. And that's really what we're hoping to achieve with this project by targeting it at people who are in the community. We want them to become peer leaders and, you know, to drive the change from the ground up, not just, you know, to be yet another group of white people from the cities telling people what to do. You know, we really, you know, obviously it needs to start somewhere, but we really want to build capacity in First Nations people to deal with this problem themselves.
I think that raises a really important point, doesn't it, Trent, that whilst we recognise these problems and we now have some tools about it, we actually need to make sure that community and consumers and the people who are First Nations owners of these magnificent places that we've seen photos of and talked about today are part of this conversation, have the skills, have the knowledge, and have, I guess, the advocacy to be able to continue to champion the cause together.
Sorry, I didn't unmute. So what would you suggest, Asha? I mean, there's this GP expert committee that's been formed. Should there be an expert committee that focuses on Indigenous, that includes it's part of the Indigenous Australians and communities?
I really think that we have to try and position this conversation in the existing conversations rather than creating new and separate ones. And so if with the GP network, making sure that one of the priorities of the very many that there are is chronic diseases, there are other things also that have to be prioritised, but that antimicrobial resistance as well as antimicrobial use and skills are positioned as a discussion point. Thinking about, I guess, at the national level and working in partnership with, say, NACCHO and the National Aboriginal Community Controlled Health Organisations, making sure that they are also aware of gaps in strategies and being able to discuss it and point to solutions as well. So rather than having separate discussions, trying to figure out ways to get this on the agenda of the many discussions.
Yeah, and I think as well, it's quite important that, you know, as we have shown with the various work presented today, is that we're not you know, there's already activities that are filling a lot of the gaps that are at the national level, and you know, focusing on it being a strength-based sort of approach rather than constantly just saying that this is, you know, the worst case scenario sort of thing. So I think, you know, we have identified quite a few bodies of work that can support some of the gaps that we currently have within the AMR strategy. I suppose it's just making sure that we're part of the conversation.
I think it's really important.
And I think a tool.
Oh, sorry, you go, Asha.
I was going to say a tool like hotspots, where you can actually fill in the gaps in the map, is absolutely essential to being able to tell that story, because it's very visual and it's very powerful. And we've gotten used to, I think, in the tertiary hospitals in particular, which I also have a role at the Perth Children's Hospital, and I lead stewardship there and that sort of thing. But we've gotten used to seeing our antibiograms and thinking that they potentially represent everything. And hotspots, as an example, gives us that information that potentially things are even worse, and that we also now have opportunities to fill those gaps. Trent, I don't know if you're going in the same direction, but
no, I was just going to pick up on something that you said in one of the previous meetings, but that following on from what Teresa said, that you know, if we can take anything from COVID, it's to really look at, you know, the success that Aboriginal and Torres Strait Islander health have had in keeping COVID out of remote communities, and you know, hopefully we can use that sort of, you know, that success to build on the bigger issue of drug resistance when COVID finally goes away.
or we learn to live with it.
Or we learn.
Exactly, that's what I was
thinking. But I do think it's a magnificent story where we've seen the community controlled health sector, Aboriginal leadership just go, we know how to work for our communities, and really put in, I guess, place the Biosecurities Act that we saw happen earlier this year. And we now have a hugely amazing achievement, and I want this to continue and continue to support this leadership, but that Aboriginal and Torres Strait Islander people have lower rates of COVID, actually reverse to what the normal gap might look like than we've ever seen. So about 0.5% of the total cases in Australia have been in Aboriginal and Torres Strait Islander people, which is remarkably different to almost every other First Nations population in the rest of the world as well. So an enormous credit to the leadership and the success and the strength of Aboriginal Torres Strait Islander people who've shown the way in COVID. And I think let's just keep doing it, build on that, build on that, build on that.
So for those of you who are listening who have roles in putting together your state's drug resistance strategies, because we know a number of states around the country are working and sort of dovetailing with the national resistance strategy, don't forget to be consulting with the Aboriginal controlled community healthcare sector and with experts in Aboriginal and Torres Strait Islander health in your jurisdictions.
Any other comments from anyone?
I mean, I think also that part of the implementation strategy is thinking about the national research agenda around this. And I think we've seen beautifully today how audits through to modelling from an antibiogram through to a text delivered solution to it, as well as the way in which big data has been utilised to actually understand what's going on, both with antimicrobial resistance as well as antimicrobial prescribing, can be used. And I guess encourage us all to keep publishing that data, keep doing the research that's needed, and keep identifying the gaps and working out ways to partner with First Nations researchers in order to build capacity and capability for that.
Absolutely, and I think, you know, the work that Sonali presented as well today from OrgTrax is really an example of, you know, the capacity that you can build a program like that. And I think, you know, with hotspots, our aim has always been about adding, combining, consolidating rather than duplicating efforts. So I think working together is definitely a key aspect of that, knowing actually what is already out there and what the gaps are rather than trying to just go on your own little agenda. So I think it's been great. It's great to hear all the presentations, and Unless anyone has any other questions or comments, I think we probably need to finish up this webinar session. So I'd like to thank everyone, all the great presenters, and I think it's just been such a pleasure to see all this work come together, and yeah, it's like a part of a story, I suppose, that you know, showcases some of the work in rural and regional Australia, which has been amazing. And thank you everyone for joining.
Thank you everyone, that was really amazing. Well done.
Thanks, Teresa.
Thanks.
Thanks.
Congratulations, everyone. That was a brilliant series of presentations, and it'd be great. I know that many of you are mad Twitterers, so once you get off, you can tweet some stuff, and we'll promote it as well.
Sounds wonderful.
Thanks very much, Kaz.
Thank you. Thanks everyone.
Thank you.
Thank you.